request Dr. Suneeta Dubey to present her talk on managing glaucoma in uveitis. Dr. Suneeta Dubey ka.
Thank you, Manisha, for the opportunity. Actually, some other session is going on in Hall 6, and I'm the moderator for that session, so I'll just finish it off and go. So my topic for today is management of glaucoma in uveitis. So as we know, uveitic glaucoma is a complex disease that often requires a multidisciplinary approach, and control of inflammation in uveitis is vital for management of glaucoma, as inadequate control of inflammatory process can cause further damage to the TM, exacerbating challenges in IOP control. In patients with uveitic glaucoma, medical therapy alone may not be sufficient to control intraocular pressure, and about 30% of the uveitic eye do require surgical intervention. So as far as pathogenesis and etiology of glaucoma is concerned, glaucoma can be closed angle or open angle. More common causes are pupillary block, peripheral anterior synechiae, and in open angle variety, trabeculitis or damage to trabeculum and endothelium secondary to inflammation. It can be corticosteroid-induced glaucoma also, which is fairly common, or a combined mechanism. So the clinical picture depends on the etiology of uveitis. I will not go in detail. So the management of uveitic glaucoma, as I said, require a multidisciplinary approach. One has to perform a thorough clinical evaluation with uveitic profile tests and ancillary tests like UBM and ASOCT. So along with anti-glaucoma treatment, anti-inflammatory treatment in the form of corticosteroids, immunosuppressive drugs, and immunomodulatory drugs are also required. However, in 30 to 40% of the patients, you need to perform surgery. So now the timing of surgical intervention is very, very important, and most of the studies recommend a minimum period of quiescence between 30 days to 3 months before performing surgery, and at least minimum 3 months is considered ideal, but one should not operate any case at least before 30 days. Now, which surgery to choose? So there are certain factors which affect the choice of surgery in uveitic glaucoma. So it depends on the status of angle, presence of peripheral anterior synechiae, and status of conjunctiva and history of previous glaucoma surgeries. So it depends whether the angles are open or closed. So if angles are open, you have a plethora of options, and now with minimally invasive glaucoma surgeries, you can perform with open angles. You have the choice of trabeculectomy, glaucoma drainage implants, etc., etc. And if there is synechial closure and iris bombay type of situation, you have to perform iridectomy, and then you can perform any of these procedures. Since repeat surgeries are quite common in these patients, you can choose to do drainage implant after trab has failed, or you can first do mix and then trab and tube. Perioperative uveitis control is very, very important, and as we know and as we work with our retina specialist, we often get the advice to use either systemic steroids or just continue on topical steroids. So this is the chart which suggests that in anterior and intermediate uveitis, if there is no activity, you can just use frequent topical steroids, and there is no need to start oral steroids. However, oral steroids should be started if there is some activity. In case of panuveitis, oral steroids have to be started if the uveitis has been inactive for less than 1 year, and if it is an active uveitis, then you have to even give intravenous steroids. So I'll just discuss 2 short cases. This patient, both eyes uveitic glaucoma, young male. He had healed pars splenitis and anterior uveitis on azuran, and he has a history of ATT, anti-tubercular treatment 5 years back. He was on maximal medical therapy, and IOP were still uncontrolled. So both eyes trab with mitomycin C were done sequentially. However, over a period of time with recurrent uveitis, he required bleb needling, and now he is controlled onto AGMs. So trabeculectomy is considered to be the gold standard for uveitic glaucoma. And they have studies have reported that there is 5-fold increase in the failure of trab if there is significant perioperative inflammation. So that brings us to emphasize on the need for control inflammation. We always use mitomycin C to increase our chances of success, and also since in these patients with uveitis there can be a compromised ciliary body and there are chances of hypotony, so releasable sutures and tight sutures are what is required to prevent hypotony. They say that exacerbated inflammation significantly correlated with surgical failure, and surgical outcomes of uveitic glaucoma may be comparable with that of normal POAG if you have, it's not going forward, yeah, just 1 minute.
Yeah, sure, ma'am.
So prognostic factors for failure of a trap include previous cataract surgery and granulomatous uveitis. Another patient who was HLA-B27 positive, he had a lot of findings in the anterior segment. There was presence of NVI, nodules, and IOP was uncontrolled, as you can see, and even cataract. So we decided to perform phaco with AGV because tube implants have fairly good success rate up to 94%, and they are useful both in children as well as in adults. Valve implants can prevent hypotony because of the presence of valve, whereas non-valve implants are commonly associated with hypotony. Minimally invasive glaucoma surgery we have limited literature, but we have started doing it now in uveitic and steroid-induced glaucoma. Cyclophotocoagulation is the last resort, and because it can lead to aggravation of inflammation as well as that it can lead to hypotony in an already compromised ciliary body, and profound IOP drop can be there. And in a study, in a study with including various diagnoses, rate of hypotony was much more in uveitic glaucoma with cyclophotocoagulation as compared to other diagnoses. So to conclude, uveitic glaucoma is a complex disease and is often refractory to medical therapy. Trab and tube are conventional surgical therapy. However, you need to control inflammation aggressively. It's a multidisciplinary approach. We work with uveitic specialists for this, and MIGS are now promising treatment, especially in open angle glaucoma stages. However, more evidence is required. Thank you very much for your time.
Thank you so much, Dr. Suneeta, for that wonderful talk. I just wanted to ask you one thing, that when we are dealing with a patient of chronic uveitis, we are always scared for hypotony because of the chronic inflammation, ciliary membranes. But sometimes these patients do present with high intraocular pressure. And so what would be the best option of managing the IOP in a chronic uveitis patient?
Yeah, so in chronic uveitis patients, basically there are in between exacerbations of uveitis, which can lead to blockage of trabecular meshwork, and already there are PAS, most of the angle is blocked. That leads to high pressures. But at the same time, because of the recurrent episodes of uveitis, there is compromise of the in the ciliary body function, which can lead to leads towards hypotony as the disease advances. So I think we need to be very careful, and that is why if we plan to do surgery in such cases, we need to be sure that we do not do non-valved implants where the chances of hypotony are more, or cyclodestructive procedure.
Right.
So I think these precautions should be taken. Otherwise, these patients should be kept on steroids along with anti-glaucoma medication.
Any questions from the audience? Thank you, ma'am. Thank you so much. Yes, please.
Thanks a lot. Thank you.
Yes.
Yeah.
Yes. Right. We are able to identify them on a UBM. And but here the dilemma was that if these patients are having high intraocular pressure, then you have to strike a balance between a cyclodestructive procedure, better to avoid them in a patient of chronic uveitis who are prone to develop a hypotony.